Hello everyone. So welcome to you again to our pediatrics discussion on university theory exam questions. So let's continue with our discussion on the common infections in the childhood. So about the measles, the measles is an viral disease. It is an RNA. The measles virus is an RNA virus which belonging to Paramyxoviridae family. So the route of the infection is by the nasopharynx to respiratory tract and subsequent viremia. The spread is by the droplet nuclei and highly contagious secondary attack rate is 90%. That is from an infected person to a normal human, the secondary attack rate is about 90%. That is measles. The measles is a viral disease that is caused by the RNA virus belonging to Paramyxoviridae family, and route is through the nasopharynx to the respiratory tract, and subsequent viremia happens. That results in the infection, and the spread is by the droplet nuclei, and also because of the highly contagious nature, it is also there will be secondary attack rate as 90%. So that is about the introduction of the measles. That is definition or introduction for the measles. Then we have the clinical features. The clinical features that is usually at the happens at the age of 9 months to 3 years of age. Usually, it is protected until 9 months by the maternal immunity. Hence, vaccine is given at the 9 months. The incubation period for the measles virus is 10 days. Highly infectious 4 days before and 4 days after the appearance of the rash. And the stages of this malarial infection, which are first stage is the incubation, that is initial 10 days, then prodromal stage, catarrhal stage, and post-measles stage. These are the four stages for in the case of the measles infection. That is incubation period, that is followed by the prodromal stage, then catarrhal stage, and post-measles stage. The prodrome stage that is lasts for about 2 to 4 days. It is characterized by the fever, malaise, and coryza and bronchitis. And then that is followed by the catarrhal stage, that is followed by the conjunctival congestion. That is, the catarrhal stage is characterized by the fever, that is followed by the conjunctival congestion, photophobia, and then complex spot. The complex spot, that is a gray spots that is over the buccal mucosa opposite to the lower molar. That is called the complex spot that is appeared on the second and third day of the measles infection. And then a rash that is on the fourth or sixth day of the fever appears the rash, that is a maculopapular rash starting behind the ears. Then it spreads to the face, neck, trunk, and limbs. And fever which increases abruptly as the rash which appears. So that is about the catarrh stage. And after that, we have the post-measles stage. There is temperature in the post-measles stage, the temperature which decreases as rash starts disappearing. That is in the post-measles stage, there will be disappearance of the rash. And after that, the temperature will be decreases. The child starts feeding and the child looks improves. Rash which disappears into a brownish discoloration, which disappears by the 10 to 12 days, but which may persist longer. So these all about the clinical features of the measles. That is usually there are four stages. That is incubation period, prodromal stages, catarrhal stage, and post-measles stage. In the prodromal stages, usual findings like fever, malaise, coryza, bronchitis will be there. In the catarrhal stage, we have the fever followed by the conjunctival congestion, photophobia, then complex spot. That is the major characteristics in the catarrh stage, and also rash appears in this stage. Then we have the post-measles stage. That is, there will be temperature decreases and as rash starts disappearing. And rashes disappears into brownish discoloration, which disappears by 10 to 12 days, but which may persist longer. So these are all about the clinical features of the measles. Then what are the complications caused by the measles virus infection? That is usually caused by the immunosuppression. That is, following the measles virus infection, we have the complications like respiratory system infections like pneumonia, bronchopneumonia, and flare-up of the tuberculosis in already affected child. Then in the GI tract, the child suffering from diarrhea, in the ear otitis media, in the CNS, the measles encephalitis, subacute sclerosing panencephalitis, which is a degenerative disorder occurring greater than 7 years following the measles infection. So this is the most important complication that is following the measles infection. It's usually asked as a 1 mark question. That is, the most common complication following the measles infection is a subacute sclerosing panencephalitis, that is SSP. And also the complications like malnutrition and in the eye keratitis and vitamin D deficiencies also following the measles virus infection. And the mortality of the measles is about 5 to 50%. Then about the management, that is how will you manage the measles infection. The management which consists of the investigation and treatment usually, and the investigation is itself is by the clinical pictures of the measles virus infection, and the treatment which consists of the supportive like oral soft diet is continued, and the tepid sponging and paracetamol for the fever. Remission and the management of the complication, that is we know that after me that is at the time because of this measles infection there will be a lot of complications in this several systems happens in the child. So the management of the complication is very much important. If they arise, the complication should be managed. Antibiotics if evidence of the bacterial pneumonia or otitis media, and the patient should be or the child should be isolated. And the vitamin A, because of the complication as vitamin A deficiency, vitamin A 1 lakh international unit in the less than 1 year old child, or 2 lakh international unit in the greater than 1 year old child, or a single dose should be administered. Then what are the post-exposure prophylaxis for the measles? In the less than 6 months old child, there is no post-exposure prophylaxis. But in the case of 6 to 12 months of age, after exposure of the measles virus or the measles, the primary source, we have to give the vaccine within 72 hours. There will be a better prognosis. And if the child is greater than 12 months and the child is unimmunized, MMR within, we have to give the MMR vaccine within 72 hours. And in an immunocompromised child, we have to give 0.5 ml per kilogram immunoglobulin intramuscularly, irrespective of the immune status. And also by the prevention is by the we are as all know that in the case in the according to national immunization schedule we have to give the measles rubella vaccine at 9 months of age, completed 9 months of age, and as well as the 18 to 24 months of age to protect the to prevent the measles infection occurring. So that is all about the measles infection. Then about the another infection is that diphtheria. So about the diphtheria, it is a potentially acute toxin-mediated disease. It is not usually due to these coronabacterial diphtheria. It is due to the toxin produced by the coronabacterial diphtheria. This infection happens. So it is potentially acute toxin-mediated disease. It is caused by the Corynebacterium species, that is Corynebacterium diphtheriae. It is an aerobic gram-positive bacilli which is arranged in V or L shape or Chinese letter pattern. And the transmission of this disease is by the respiratory droplets or droplet nuclei, and also by the direct contact with the respiratory secretions or with the contact with the fomites and dust. So these are the route of transmission of the diphtheria. Then about the clinical features of diphtheria, it is usually occurs in the unimmunized children below 50 years. So in a question regarding the diphtheria in our essays also, there will be a word like unimmunized children or partially immunized children will be there. So we have to identify it as a diphtheria. So usually unimmunized children below the 50 years of age, we have get affected with the diphtheria. Nowadays, adolescents and adults which are more prone for the diphtheria infection. And usually in the autumn and winter season, there will be more chance for the diphtheria infection. And incubation period for the diphtheria infection is about 2 to 5 days. The pharyngeal diphtheria is most, there are different type of diphtheria. There is pharyngeal diphtheria, laryngeal diphtheria, and cutaneous diphtheria. The pharyngeal diphtheria is most common form. It is presented with a sore throat, generalized malaise, low grade to moderate grade fever, difficulty in the swallowing because of sore throat as well as the exudate, whitish tonsillar exudate. And it is also present with the whitish tonsillar exudate, grayish membrane adherent to the tonsils and bleeds on touch. Membrane which may extends to involve the uvula, soft palate, posterior oropharynx and hypopharynx or glottic area. and underlying soft tissue edema and enlarged cervical lymph node, which may be also be prevent, which may gives a bull neck appearance and stridor. And also there will be the child present with the Vincent's angina, that is there will be a swelling at the submandibular area, and also there will be acute epiglottitis will be there. And the pharyngeal and another type of diphtheria is the laryngeal diphtheria. That is characterized by the hoarseness of the voice, croupy cough, stridor, and respiratory distress. And the cutaneous diphtheria is very rare form of the diphtheria. So these are all about the clinical features of diphtheria. The complications, we already taught that it is a toxin-mediated infection. That is, diphtheria is a toxin-mediated infection. So the complication due to the toxin is first important one is the myocarditis. Then, what are the differential diagnoses for the diphtheria? The viral or the streptococcal tonsillar pharyngitis is a differential diagnosis, and the Vincent's angina and acute epiglottitis, these are the differential diagnoses for the diphtheria. Then, how will you treat the diphtheria patient? Uh, it's all that is the infection is all because of this toxin mediation. So we have to neutralize the toxin rapidly by the anti-diphtheric serum. And the mainstay of the treatment is should be administered. It is the mainstay of the treatment. That is neutralization of toxin by the anti-diphtheria serum is the mainstay of treatment. So it should be administered as early as possible. It is given by the IV or IM route after skin sensitivity test. The dose of the anti-diphtheric serum, which depends upon the site of the infection. That is, if the infection is on the nasal area, it is we have to give the 20,000 units of anti-diphtheric serum. And if there is tonsillar and pharyngeal site is involved in the infection, 40,000 to 80,000 units is given if 48 hours or less in duration. In case of laryngeal diphtheria or extensive disease of more than 3 days in duration or with the neck edema, we have to give 80,000 to 1,20,000 units anti-diphtheric serum. Then also we have to give the antibiotics. That is drug of choice is penicillin. That is aqueous crystalline penicillin G. 1 lakh to 1,50,000 units per kilogram per day should be administered. Alternatively, erythromycin, which can be given. And antibiotics for the 40 days per until throat culture is negative, we have to give the antibiotics. Then we have to give the supportive care, like we have to isolate the child and bed rest for the 2 to 3 weeks. Proper hydration and nutrition should be provided. And tracheostomy in the patient with the laryngeal obstruction. Because of the laryngeal obstruction, the child will not be able to breathe properly. So we have to put the child on the tracheostomy, and all the contacts without the full primary immunization and a booster within preceding 5 years should receive a diphtheria toxoid. All the contacts we should receive the diphtheria toxoid. Then how will you prevent? That is, we according to national immunization schedule, we have to give the DPT vaccine to all the child, and all the contacts, that is unimmunized contacts, should be given DPT vaccine, tetanus, diphtheria, acellular pertussis in the adolescents. So by this, we have to prevent the diphtheria from happening. So that is all about the diphtheria. Then about the tetanus. Another infection that is usually happens in the childhood is the tetanus. So it is an acute and spastic paralytic illness. It is caused by the Clostridium tetani species. That is an motile gram-positive spore forming obligate anaerobe, and it is produces a neurotoxin tetanospasmin which causes this tetanus in the children. So bacilli which enters through usually the Clostridium tetani bacilli that which enters through the any wound which happens in our limbs or other areas, especially in the unclean wounds with the dirt and debris. These bacilli which enter the wounds into their body, and also autogenic tetanus is because of the entry of the bacilli from the pus. The It is not contagious from the other. Usually, the tetanus infection is not contagious from the person to person. It's not transmitted from the person to person. Only vaccine preventable disease that is infectious but is not contagious is the tetanus. And the incubation period for the tetanus is about 10 days. That is actually is 3 to 30 days, and the average is 10 days. And the clinical features. So when these bacilli which enters to the wound into our body, the clinical features are manifested. That is, three types of clinical features are there. The generalized, localized, and neonatal clinical features are generalized. Tetanus is most common. That is, usually there will be a descending pattern of the presentation is there. That is, first sign of the tetanus is trismus or lockjaw due to the masseter muscle spasm. and there will be headache, irritability, and restlessness are the early symptoms. This is followed by the stiffness of the neck, difficulty in the swallowing, and rigidity of the abdominal muscles. Then we have the rhizus sardonicus, that is grinning-like appearance resulting from the spasm of the facial and buccal muscle. There will be rhizus sardonicus, that is a grinning-like appearance. And then we have the opisthotonous posturing of the body, that is rigidity and spasm of the lumbar and abdominal muscle causes an arched posture, that is extreme hyperextension of the body, that is called the opisthotonous position. Then also it causes a board-like rigidity due to the total contraction of the opposing muscles. And there will be laryngeal and respiratory muscle spasm, which can lead to the airway obstruction and asphyxia. The sensory nerves and cortical functions remains unaffected. Hence, the patient remains conscious in extreme pain and in fearful anticipation of next tetanic seizure. The seizure, which are characterized by the sudden, severe tonic contractions of the muscles with the clenching of the fist, flexion and adduction of the arms, and hyperextension of the lens. The seizure, which may initially last for a few seconds, but gradually becomes sustained and exhausting. Then smallest disturbance, which may by the small disturbance by the sound, bright light, and touch, which may even trigger the spasm in the body. And constipation and retention of the urine, which may result from the sphincteric muscle spasm. Autonomic disturbances like hyperpyrexia, hypertension, excessive sweating, tachycardia, and cardiac arrhythmia, which can also occur in the case of the tetanus. Then about the neonatal tetanus, when umbilical cord is cut with an unsterile instrument, that is, if the cord is or if the cord stump, umbilical cord stump is covered with a dung or any unsterile packing is made there, and also the use of an unsterile instrument which causes the neonatal tetanus, which is manifested within 3 to 12 days of birth. A generalized tetanus, and seriously it is neonatal tetanus is fatal. And diagnosis is by the usually by the clinical unimmunized child or baby born to unimmunized mother. Usually we are suspicious of the tetanus. And how will you treat the tetanus infection? The human tetanus immunoglobulin, that is dose is 500 to 1000 international unit, and we have to give it through intramuscular route. No effect on toxins already fixed to the neural tissue. Does not penetrate the blood-brain barrier. Neutralizes circulating tetanospasmin, hence given as soon as possible. Then we have to give the antibiotics. That is, penicillin is the drug of choice, and the penicillin G, 1 lakh units per kilogram birth weight, four times a day for the 10 to 40 days intravenously. And the metronidazole can also be given, erythromycin or tetracycline for the penicillin allergic patients. And we can also give muscle relaxants in all the patient with the generalized tetanus. That is, we have to give diazepam provides both relaxation and seizure control. Initial dose of 0.1 to 0.2 milligram per kilogram birth weight every 3 to 6 hours given intravenously. Dose subsequently titrated to control tetanic spasm. The sustained for the 2 to 6 weeks, tapered gradually. Then we have to also give the supportive care like the surgical wound excision and debridement to remove the foreign body or the devitalized tissues. Patient should be kept in quiet and dark environment with the minimum or through the visual stimuli, because these stimuli all are stimulates that spasm. So we have to avoid that stimulation by the patient in the quiet and dark environment with the minimum or through the visual stimuli. Then minimal handling of the patients, intramuscular injections to be avoided. Maintenance of the nutrition, fluid, electrolyte balance should be provided. And then how will you prevent the tetanus? Active immunization should be begin in early infancy. Immunization of pregnant women with the TT, which prevents the neonatal tetanus. We have to, according to national immunization schedule, we have to give the tetanus and diphtheria toxins throughout our schedule. Clean delivery and cord care, which prevent neonatal tetanus, and proper wound management as per the recommendations. That is, after a wound, we have to take an TT immunoglobulins. So we have to prevent the tetanus from occurring. So these are all about the certain common infections usually happens in the case of the children. Thank you.